Good afternoon in New York and the Americas. Good morning in Arizona, California, and South Dakota. Good evening in Europe, Israel, and Africa. And welcome, whatever time of day or night, for all of you who are joining us from all corners of the world. I'm Yael Danieli, founder and executive director of the International Center for the Study, Prevention, and Treatment of Multi-Generational Legacies of Trauma, ICMGLT for short. Thank you for joining our webinar today. This International Center for Multi-Generational Legacies of Trauma's webinar takes place on Indigenous Peoples Day in the United States, a federal holiday to honor the cultures and histories of the Native American people. Today's webinar will focus on the multi-generational impacts of COVID on Indigenous communities across the United States. Following a background presentation, we bring together members of two Indigenous tribes to reflect on their experiences and lessons learned during and after COVID-19, and the tribal values and resources their communities draw upon to live through the pandemic, survive, and strengthen both their communities and relationships, and thrive. Your moderator, I am a clinical psychologist, victimologist, traumatologist, and psychohistorian. I devoted much of my career to studying, treating, and preventing multi-generational impacts of massive trauma, to victims' rights, to rights of future generations, and to reparative justice. My version of psychohistory is related as it is dedicated to articulating history as it is lived, rather than as mostly a series of dates and events. Today's first speaker is Dr. David Goldberg, MD, a primary care physician who, upon completion of medical school in 1983, he trained and then worked in the division of general internal medicine at the public hospital in Chicago, Cook County Hospital. In 2014, David moved to Chinle, Arizona, to work for the Indian Health Service. He is an adult primary care provider and works with the Chinle Service Unit Diabetes Program. Our second speaker is Anpotowin Jensen from the Kiuksa Tiospe of the Oglala Lakota Nation. Anpo was born and raised on the Pine Ridge Reservation in South Dakota and graduated with a master's in civil and environmental engineering from Stanford University, where she was the first Native woman on Stanford's Student Global Health Board. As a writer, author, and poet, she interweaves her experiences as an Oglala woman, engineer, and advocate for Indigenous solutions in global health and climate change in her creations. Finally, we have Miranda Williams. From the cool waters of the Oregon coast, Miranda is an enrolled member of the Siletz tribe. Miranda works in Chinle Service Unit, Navajo Area Indian Health Service, as a supervisory public health advisor from 2011 to 2022. With 19 years of experience in public health and clinical care systems, program development, implementation, and evaluation, in 2022, she returned home to work for her tribe as the Executive Health Director, Silet's Community Health Clinic. This webinar is all our webinars with this focus could not have happened without the generous help of Dr. Mary Fabry, our board member and co-chair of our working group on Indigenous Peoples issues. And today I also invite formally both Anpo and Miranda to not only teach us today, but join our work from now on. We have an hour and a half for the webinar. Each speaker will talk for about 10 minutes. Following an interchange among us, I will open the floor to questions or brief comments from the virtual audience. Panelists will then conclude with what we call last words. Please use the chat function and we will do our best to respond to as many as we can. Feel free to direct your question to a particular panelist or to the full panel. We begin with Dr. David Goldberg. David, the screen is yours.
Let me pull up my slides. Okay, so I'm assuming everybody can see them. Well, thank you for inviting me to participate in today's ICMGLT webinar on Indigenous Peoples Day and this discussion on the impacts of COVID-19, of the COVID-19 pandemic. I've been asked to give a kind of very brief overview of data on Native American health. Before I start with my slides, I want to honor my many co-workers and other essential workers here and elsewhere who did so much to get us through the worst days of the pandemic. They and all their families sacrificed so much in Chinle for our community and for each of you who are viewing this webinar in your communities as well. I'll share health-related data, first preceding the pandemic and then from the pandemic itself. At the end of the presentation, I want to highlight new work by Native American scholars who really aim to change the our understanding of health and of the kind of work being done to improve Native American health. I'm mostly going to be speaking in very broad generalities, and generalities risk missing much of the richness and diversity of Indigenous experiences and cultures. Anpo and Miranda will begin to illuminate the particularities. There are currently 574 federally recognized Native American tribes, and there are well over 200 language groups within the Native American peoples. Additionally, there are approximately 400 unrecognized tribal groups, some of which are quite small. Considering these numbers and the diverse locations from which Native American peoples originate, I hope you'll keep in mind the challenge of looking at summary statistics and lumping all Native Americans into one grouping. And although we commonly think about reservations as the current homelands for Native Americans, it's important to say that Native Americans live in many places and amongst us all. This map shows the population density of Native Americans at the county level, and in some counties, particularly where they're in northern Alaska and where there are reservations in the continental US, Native Americans are the majority. But the legend on the right-hand side of the map shows that the largest Native American populations are in the cities of Los Angeles, Phoenix, Honolulu, Houston, and Chicago. Native Americans live on and off reservations in many diverse settings. Turning now to health, I want to begin with a study describing middle-aged mortality rates in the United States. The authors use data housed by the CDC that includes causes of death. They limited the analysis to deaths in between the ages of 25 and 64 that they called middle-aged deaths, and for the time period of 1999 to 2016. While many national data sets or publications do not include Native American Indian or Alaska Natives, this publication does. This graph shows trend lines for mortality from all causes. The x-axis are the years from 1999 to 2016. On the y-axis, we have age-adjusted mortality per 100,000 people. Lower mortality, of course, is better. Starting from the upper left, the brown line is African Americans, the blue line is American Indian and Alaska Natives, yellow is non-Hispanic whites, gray Hispanics, and red is Asian and Pacific Islanders. Along each line, you'll notice that there's a capital letter N, demonstrating the nadir for mortality for each of the racial ethnic groups. So one finding is that for each racial ethnic group, mortality turned a corner, the change from improving to worsening over time during this time frame of 1999 to 2016. By itself, this is a disturbing finding. For Native Americans, the nadir was reached approximately a decade earlier than for other populations. And by the end of this time period, middle-aged mortality for American Indian and Alaska Natives was the highest among all racial and ethnic groups. The series of graphs on this slide breaks down the causes of death by race and ethnicity. And we're not going to look at details, but if you can find the blue line showing data for American Indian and Alaska Natives, you'll see that for most causes of deaths, the line is sloping upwards, where for two of them, there's kind of relative stability of the data. I want us to take a moment to think about why is this happening? Worsening middle-aged health across all ethnic groups and with an acceleration of this phenomena amongst American Indian and Alaska Natives. A common explanation is the term the deaths of despair, rising suicide, overdose, and alcohol-related liver disease. Another is to use the language of the social determinants of health. This refers to the policies, economy, and culture that creates poverty and indebtedness, precarious housing, a broken food and agricultural system making unhealthy, ultra-processed foods a larger part of our collective diets, and global warming and other environmental exposures in the air, water, and land. The list of external threats goes on. I prefer to use the social determinants of health to the deaths of despair as the focus stays on the social system and our collective action and not the individual's response. And sometimes people lapse into thinking responsibility for despair. For Indigenous people, the impact of colonialism is considered a social determinant of health. The Mississauga Nishnabeg writer and activist Leanne Betta-Samasoke Simpson wrote in the book Rehearsals for Living how settlers work to build not just their home places on top of ours, but a world on top of ours, but a world based on civilization as enclosure, freedom as property, and happiness as amassing violently extracted wealth. You can imagine how this friction and dispossession repeated over generations between Native Americans and the dominant settler populations would harm health. The pandemic arose in this background. To give you a picture of the impact of COVID on Native American health, I'll show you data from a couple of papers. The first study, again, used national data. First, the authors calculated pre-pandemic mortality rates using the time frame of January 15th to the end of February 2020. Then they reviewed deaths from March 2020 to the end of 2020, looking at the rates, and since they were higher, being able to calculate excess death rates that occurred during that first 10 months of the pandemic. They calculated the number of excess deaths and then categorized them from death certificates as to whether the deaths were attributable to COVID-19 or indirect mortality from other causes. They looked at the deaths by age and race and ethnicity. In the second column, you can see that American Indian and Alaska Natives had the highest rate of excess mortality of any of the race ethnicity groups. The excess mortality attributed to COVID was also highest. Then the non-COVID excess mortality during that period of the first year of the pandemic was also high, second only to African Americans. The non-COVID deaths likely reflect barriers in the health system created by COVID, but also intensification of social determinants of health during the pandemic. When we look at excess mortality by age, the ratios among younger people are striking. Between 0 and 29, excess mortality rate for American Indian and Alaska Natives, though while relatively low, is 4 times larger than for whites. Between 30 and 49, the excess mortality is 5 times larger. Between 50 and 69, 3 times larger. And for the elders, excess mortality is 1.6 times higher. The pediatricians in Chinle talk about how frequently in their clinical encounters, children that they're seeing have lost parents or other close family members. Some children lost multiple family members. There's much heartache behind these statistics. Steve Wolf recently reported on changes in life expectancy as a result of the pandemic. In this paper, Wolf and his colleagues calculated life expectancy for the US overall, for 5 racial ethnic groups, and then also for 20 high-income countries that he refers to as peer countries. Between 2019 and 2022, peer countries lost well below 1 year of life expectancy. In comparison, in 2019, before the pandemic, people living in the United States had almost 4 fewer years of life expectancy compared to peer countries, and then during the pandemic, lost an additional 2.4 years. For American Indian and Alaska Natives, in 2019, the life expectancy was 7 years shorter than the average for the US and 10.8 shorter than the international comparison. During the pandemic, American Indian and Alaska Natives lost nearly 5 years of life expectancy. So I'm going to change directions now. Reflecting enormous commitment, hope, and resilience, there's a growing number of publications written by Native American authors. Here's one. For this study, the authors enrolled 192 participants with diabetes from 5 Anishinaabe communities of the Upper Midwest. They were interested in learning more about the self-efficacy to manage diabetes, and they used the term diabetes empowerment. Specifically, they were interested in the intersections between support, culture, and diabetes empowerment. On the x-axis, there are 3 levels of diabetes support, from low to high. Then there are 2 lines. The bottom line represents persons who were self-described as having low Anishinaabe identity, and on the top line for persons with high Anishinaabe identity. At each level of diabetes support, identity further augmented empowerment. While a small study, we read this in our Chinle diabetes program and shared it with frontline Navajo staff members with the message that their presence, the knowledge they hold about diabetes, their membership in the community, and the work they do incorporating Navajo ways of being into healthcare is of tremendous importance to our patients. There are other examples of studies like this reflecting the importance of culture for diabetes, mental health, and substance use prevention. It's wonderful work. And then finally, this is a recently published paper. The paper summarizes the work of 27 Indigenous health researchers. They gathered to define an Indigenous strength-based approach to health and well-being research. They describe their work as shifting the focus from illness-based approach that dominates medicine and medical care to one of flourishing and relationality. The recommendations bring Indigenous identity, values, and culture to the center of the goals, formulation, context, process, and communication of research. It's clear that this small and dispersed group of researchers are supporting one another as they forge new work in their communities. In these difficult times, their approach is filled with optimism flowing from their communities and cultural ways. It's an exciting and inspiring vision. So just like Santa and his sheep have lots of work to do, I'm going to hand off to my co-presenters now and say thank you very much.
Thank you, David, for a brilliant presentation of both the horrible tragedy and of how to heal, and all scientifically based. Thank you so much. I know there's so much more to say, which we will do when we speak together. And please, there's one point I must say after your presentation. Everyone knows, or if you don't know yet, we at the center has the largest, richest library, last minute quality library in all professions and disciplines related to multi-generational legacies of trauma. While we pride ourselves to have the richest one and aim at that, we are humbly asking all of you to check out if we are missing anything and immediately send it to us so we add it. That's how we make it the richest library. And David, please check against, check your references against our references and just send them in. Thank you so much. And Anpo, dear, beautiful Anpo, the floor is yours now. I mean, the screen or floor, whatever.
Well, thank you. I don't have slides today. I'm going to take a storytelling approach to the experiences that the Lakota Nation had with the onset of the pandemic. So, hello everyone. My name is Anpo Tchomi Jensen. You can call me Anpo. I'm from Pine Ridge, South Dakota. I recently, in 2021, I graduated with my master's in environmental engineering. Also studied at Stanford for my bachelor's there in environmental engineering. So that's the ground or the foundation, the lens that I have in academia. But while I was there, so what I noticed was my experience as a young person was kind of a microcosm of what was going on in the globe. So I came straight from the reservation. I went to school, and I started to realize there aren't any solutions for Indigenous peoples within the United States. And most of that, I believe, came because they didn't recognize us as sovereign nations with our own culture, our own language, our own history. And so, and all of that is a strength. It's always been a strength for our people. So I wanted to take that strength and exercise it, that sovereignty. And so I advocated to be on Stanford's Global Health Board. And one of the questions they asked me, have you ever been abroad? And at the time I said no, but I come from the reservation. We have our own president, we have our own healthcare system, we have all of these things that are independent and sovereign from the state, and is recognized by the federal government as a tribe. And so knowing those dynamics, those political dynamics, I really wanted to exercise our sovereignty in that aspect. So I was on the board, which was awesome. And I got to experience and see solutions that were developed for developing countries, or the global south is what we call them. Countries that are in poverty, or experience high levels of poverty at the expense of like extraction from mining and other things from countries like the US. And and so because of that, I started to see we had more in common with the rest of the world than they led us to believe, right? We've been on reservations, and that essentially kind of cut us off from the rest of the world. It cut us off from our own traditional patterns and how we operated in the ecosystem, in the climate area. So with all of that, that's just a little bit of I guess a tangent. But where I came in with all of this life experience was when the pandemic started, and I already had all of this context, this history, this upbringing, this education. Stanford was, well, actually, so a woman named Dr. Sarah Jumpy Eagle reached out to Stanford she worked at IHS, the Indian Health Service, and she, being an Oglala and Dakota woman, she understood that we already had a lot against us, and with the pandemic, the impacts would be way more harsh on us because of that, those systemic issues that we face and have faced over the past couple 100 years. So we knew our place, I would say, and we knew that when this pandemic were to start, or when it was going to hit our homelands, that we had to prepare. And that was one of the things about my people, is we have a lot of value and humility, and understanding where we are and recognizing what we have. We have the lowest health disparities in the Western Hemisphere. We have the lowest life expectancy. We have the lowest poverty rates. And so all of that, and knowing that there are solutions being thrown at us that we know, sometimes are unattainable. And that was a thing with even in engineering too, is a lot of solutions that are thrown out there are unattainable. So backtracking, what happened was, after Dr. Sarah wrote to Stanford, the Global Health Center there, they answered the call, and they were more than willing to go and help set up ICU units and help kind of expand the healthcare that was already there. Because at the time we only had, I think, like 8 beds, and we have a population of like thousands, like 4,000 or 5,000 on the reservation, a total population of 30,000 enrolled members. So it really did seem overwhelming for a clinic. Knowing the stories that what happened to other Indigenous nations, knowing the stories of what's happening to other communities that were struggling. And so what we did was we exercised our sovereignty, and I was going to refer to that. what happened was the tribal government closed their borders and said, what's going to happen is we are going to monitor anyone who leaves and comes in. We're going to close our borders from tourists, and we're going to protect our people. Now imagine that in a state where they weren't prioritizing PPE, they weren't prioritizing social distancing, they were actually not believing in the pandemic, that the pandemic was actually happening. So we knew there was a lot against us and a lot surrounding us. And so once the borders closed, then that's when IHS got to work, and they started working with Stanford and the tribe to prepare. But where I came in, and this is why it's really important to invest in Indigenous youth and in Indigenous voices, is I came in already in a leadership role, and I was asked to help facilitate this partnership that was happening because I was already in Stanford and in the global health realm. And I also had the context of, what was happening on ground. And so what happened was I created culturally competency or humility trainings for them, so that when they went to Pine Ridge, that they were aware of all of the things that they'll be seeing, the cultural aspects, the history. I think Miranda might mention some things about distrust in the healthcare system. I had to recognize that with them and realize and share that the reason why there isn't trust. So it's not really about them personally. It was more about this history. And so just bringing more of that context into, their experience, but then also coming at it from a lens of we are already an empowered Indigenous nation. And we've always been, we've always prioritized the lives of our elders. We've always prioritized, our relatives. Having that connection is one of the most important things to us. So a lot of the things that the virus or the pandemic, quote unquote, threatened, were essentially a lot of those threats were, kind of coming at us in a challenging us in that sense. And so we had to think of solutions and ways to overcome that. But sorry. So the doctors did go, the team of nurses, Stanford's team did go to Pine Ridge, and they actually kept the cases on the reservation down to 13, which is remarkable because we're literally in a sea of people who weren't wearing masks. There was a lot of political pushback, but to see that number stay low and not to experience that type of intensity that we were seeing all across the nation was really powerful. And it was really awesome that the Stanford team, the recognized leadership on all fronts. So they recognized Dr. Sarah, who was from our tribe, leading that. They recognized me. I was in leadership of where I was in my career. And so just elevating and looking for that Indigenous-led leadership on all levels is really important because it all has a place. And so, yeah, one of the things that is really interesting too is as an Indigenous woman, I have a responsibility to my people and my community. And so when I go to school, a lot of the times I go to school because I'm thinking of how I'm going to help. How am I going to best serve them? And that can be challenging too. I remember when I think it was in 2021, when I was finishing grad school, I was literally studying water systems, and how to provide water systems while I lived in a trailer with COVID, without running water in the middle of winter. So it was a lot of the things that I was studying were really applicable to my experiences. And so that's kind of where our strength comes from, is we have this element of resilience and humility and trust that we'll get through it. But it was also recognizing our shortcomings, right? We don't have the money, we don't have the healthcare, to handle this? How do we reach out to relatives that are not from our nations, and make those connections and utilize that support? Because I think that goes back to when they when they put us on reservations, they tried to cut us off from the rest of the world, but a medicine was to reach out and to have that relationship building between us and Stanford STEAM or other doctors that were interested in helping and wanted to help. So I think that's really powerful, is that element of connection and building those relationships and nurturing them. So I went on a bit of a long-winded story, but I hope to answer everyone's questions at the end and clarify if there's anything you want me to talk more about. But thank you.
And this is how we are establishing our relationship and your relationship with our community, which is so deeply moving. And when I first heard Anpo speak, I felt like, oh my God, this is a miracle story. We must put it against the tragedy, the horrible tragedy, and learn from it. And another thought, of course, is that relates to our center. Some of you know we give we name our awards the Repair Awards. And what Anne was talking about is repairing, right? Using everything to repair old wounds, current wounds, prevent new wounds. So thank you so much, dear. And yes, there's so much more to learn. And David, you could probably comment later about what you presented vis-a-vis Anpo's presentation. So I look forward to our dialogue. And now we have Miranda. And one of the shocking things about Miranda is she has 5 children. Now look at her, and you forget that one.
Yes, and
dear Miranda, floor is yours.
No, it's okay. Thank you. Yeah, and tribal communities' children are a blessing. And so I have 3 sons, 2 daughters who are from the same tribe that I'm from. They're Siletz, but they're also half Navajo. Yes, I don't know how I manage. I just do it. An Indian woman. Did you want me to pull up my slides? I just have a few.
Take your time. We are doing fine time-wise.
Okay. Let me see here. Okay. I think this is the screen that I want to share. And okay.
See,
Can you see my screen? Okay.
Mm-hmm.
Okay. And let me actually, sorry. This gets really confusing when is this okay?
Yeah, it's perfect.
I wanted to see my notes, and so I have 2 screens, but my I can't see my notes, and so but let me make this a little bit better. Okay. All right. All right. So I just have a couple of slides, and I wanted to talk about just the importance of American Indian culture and connections. And this is really to improve the health and wellness in our tribal communities post-COVID. And Chela, Kiwati, hello everyone. My name is Miranda Williams. I have a master's in public health, and I've had, just many experiences, just, as far as my journey with my own tribe, and then also with my education sort of brought me to where I'm at now. And so culturally, first, actually, just wanted to show you this, this dance house, this first picture. And this is a place that's really important to my people. It's a place of celebration, a place of prayer, a place of song, ceremony, a place that we're together. And this is, important for the people of Siletz. And we have various ceremonies that happen throughout the year in this dance house. And this is a way for us to come together as people to do that. And I just wanted to share this picture with you all on where I'm from. So before I go into the demographics of Siletz, as an Indian woman, that connection is really important. Talking about who you are as a young person. When I first started working for my tribe, I had both the introductory part of who you are is really important. So elders like to know who you are, who your family is, before they even start talking about their health. They'll tell you stories, and then the last 5 or 10 minutes of you being there, they'll start talking about those things that you want to talk about, which is, for me was health related, given, my field. And so, so I'm a member of the Confederated Tribes of Siletz Indians. I have 5 children, 3 boys and 2 daughters that are Siletz and Navajo. As a young person, I learned that relationships are really important with family and community. It's important for us to connect. It's important in that connection between us. And also for me, growing up, those introductions were important to the elders. And so they really reiterated that, knowing and making sure that you introduce yourself, your family and who you are. And so that was really instilled in me. And I always did that every time I went into a home, just, being welcomed by the elder or a family, and then just kind of introducing myself and just, sharing. Culture, language, beliefs, ceremonies, song, connections to earth through creation story, teachings are really important to my identity, but also to many Indian people's identity. And I know, through my journey, when I was going through school, I moved about 20 years ago from Oregon to Arizona to go to school. I went to Arizona State. And before I left, I identified an area that I felt like was a gap, which was around nutrition and being able to talk with our elders, with my community members about prevention, and particularly around diabetes. It's such a huge issue for my tribe and many tribes nationally. And so I really had to look at what were some of the barriers, what were some of the health beliefs that, that I had in myself that kind of, definitely has been passed down to me. And I discovered that earlier relationship with the health system was negative. And I only really accessed healthcare and urgent and emergency situations. That's the only time that I really accessed healthcare. And really it's because I didn't have a trust of the system and really had no relationship. And really looking at this through my mom, through my grandmother and other relatives, there's really that intergenerational trauma around the healthcare system. And so it wasn't looked at in a good way. And I really wanted to change that. And so I started looking into that even more. And so when we're looking at, this picture of where I'm from, there's the United States map on the right, bottom right. that shows Oregon, and then there's the star, which is where my reservation's at, where my people are at, and then just above that is kind of, you know, Oregon that has the state name, and then to the far left is our reservation lands just prior to termination, and so. What that meant was for Indian people in the 1950s is they were no longer recognized as Indian people. They're the tribes that went through termination and then were forced to assimilate. And so to be, you know, just like everyone else. So they were no longer recognized as Indian people. So the lands before termination, even before termination, were from the southern Washington border down to the northern borders of California. So those were our initial, you know, lands that were occupied by my people. Prior to that, though, and these were 27 tribal bands that, you know, populated that area. But just before termination, that land has shrunk just through, you know, treaties being broken and sort of that, you know, the settlers moving into the area and the land being sold. And so it was diminished to the coastal areas, which are Lincoln, Tillamook, and Lane counties. And these are areas within the Oregon region. And in 1956, the Western Oregon Termination Act declared that people of Siletz tribe were no longer Indians. And this was what other tribes were facing as well, not just the Siletz tribe. And as a result, more of the land was sold to settlers, and then also the town of Siletz was also sold. The impact of termination and assimilation caused a loss of place, language, identity, resulting in extreme poverty, disease, starvation, death, and then, you know, just ultimately resulting in no trust in the government. But through this, you know, Indian people, you know, they're resilient. They've proven they've been able to be resilient and really coming together, you know, culturally and through family in order to, you know, come to Congress and say, and this was in 1977, that the Siletz tribe, we have the right to self-govern. We have the right as people to be recognized as Indian people once again, and that's when we were recognized. There was a Siletz Restoration Act where we gained our recognition again as Indian people. As a tribe. The reservation land now includes approximately 39 acres, which isn't very much when you look at it. And there's 3,600 acres of timberland throughout the Lincoln County area. So it's not too much land, but it's a starting point for my people. I just wanted to give you this picture of, you know, where that intergenerational like trauma has come from. It started there and even before that. And, you know, my people really had to be resilient, just like other tribes, just like other Indian people across the country, and really, you know, rely on family and community for that strength. And so fast forward, going into the reflection of, you know, my COVID-19 experiences. So pre-COVID, I was really working on some amazing initiatives. I was working in the Navajo Nation, and I'm working actually with David, Dr. Goldberg, during this time around patient-centered care. And we really focused on relationships, transition from transactional care, which is really about treatment, referral, and getting medications refilled, and really focusing on the actual person, There was value in care through connections, just really looking at Navajo relationships, what's important to the Navajo people, like acknowledgement of clans, family, cultural beliefs, ceremonies, language, health literacy, as well as integration of services such as the Office of Native Medicine, which is really kind of what they did was they merged sort of the modern and traditional medicine for that balance, for that connection, to respect the culture of the Navajo people, as well as other services that, the community members said that they would, that they wanted closer into where they were getting care. And they really showed outcomes that really improved engagement and activation in care, as well as clinical outcomes. And so we were really, during that time, really showing, that this is all about, the people of Navajo, the way they would like to receive care, and how they kind of saw their relationship with the providers, as well as others working, in the clinic, and being able to determine what that need was. And so that was really important in the work that was being done. And I really, as a child, kind of thought about, or as an adult, not as a child, but as an adult, really thought about when I was a child, really looking at, when I used to kind of listen to my elders when I would go into their visits with them before I moved to Arizona, just listening to kind of how they communicated and how providers kind of looked at them like they didn't care about their health, or didn't really understand, what was most meaningful to them, as an Indian person. And so it really showed it made a difference in integrating, culture into the care of the Navajo patients and community. It really showed that we cared, me as as an Indian person, but also the providers that were working there. Then during COVID, the initiatives were directed to getting needs met, which made sense, but it was definitely detrimental to the people of Navajo. So the options for care were remote services, such as telehealth, and again, more of that transactional care around treatment referrals, and then just around medication, which I think met the needs, but still were far remote and not relational to the people. So again, there was more emphasis on that transactional care and less emphasis on relationships and connection. Post-COVID, there was, still the shift not to get needs, to get needs met, rather than the focus on relationships. So there was models that were shown that really met the needs for healthcare professionals, not the patient. So when post-COVID, I did move from Navajo to come to work in my own community as the executive health director. And this was really around the post-COVID time, but really we were already seeing some of the barriers and some of the outcomes from COVID, just from the transactional care, and really going far from what we were trying to get to pre-COVID around relationships. And so what I saw when I was in Siletz, while I'm in my own community, was there's more telehealth models for healthcare professionals. And it really takes, especially when you're working in mental health, behavioral health, and really any healthcare field, it takes time to build relationships. It takes time to build that trust, especially with that intergenerational trauma with tribal people. And so there was really that lack of less emphasis on the importance of relationships. there's less value on understanding the cultural needs and connection that's needed for engagement and care, and really adding to intergenerational trauma. So it already existed there already with Indian people, but
Are you okay? Miranda? Miranda? Are you okay? Are you with us? Miranda? Miranda, it seems like you're frozen. Do you hear me? Thank you, Jill.
can you hear me?
Yes, thank
Okay.
you. I'm so glad you're back. Go ahead.
I'm almost done. I wanted to kind of add some steps forward in a positive way, and excuse me. So understanding of challenges for people to be engaged in their own healthcare. Oops, I forgot. Let me just make sure we pull this up. Oops. Okay. So steps forward in a positive way. I'm talking about understanding the challenges for people to be engaged in their own care, related to whether they work on and off the reservation, what their health beliefs are, their trust. So, for example, like myself as a young person, just really, growing up around just utilizing services that are urgent and emergency care, and not really, understanding like, oh, I can, go in and get health care for prevention. Really, what does that mean for me in my generation, and how can I talk to generations, below me on what healthcare means for them, and sort of changing that, transforming that. So, in this knowing there was different experiences during COVID impacting the health of tribal communities. So where I'm from, mental health, and I know this is for many, tribal communities, chronic stress, drug and substance abuse, and really understanding that stigma and trying to find a way to really work with tribal communities to address that, and know that there was, continues to be a, food deserts, like just poor food environment, reduced opportunities for physical activity. There's still, fitness centers and other places across tribal communities where some of that repair needs to be done, and that support. And then, also just, family. And, during COVID, families didn't really have that opportunity to grieve, and the way that, they would do culturally, whether that, be, being with their family during that time and being able to have, gatherings and ceremony, or prayers, and that just not being able to happen, being able to put people into the earth the right way, or whatever way, for that tribal community. And, really looking at, the tribal communities, who, just that whole distant learning was really hard, because of connection, and because of, various reasons, kids weren't able to get the best education, in the system that was existing back then. So socialization is really tough, not just in tribal communities, but around the world, once in classrooms and return to in-person. And just the changes in, social support is just the result of, the change of, that's happened as a result of COVID. And there's just new health demands at this time. And I know that the clinic that I work in, dental, is they are booked out several months in advance. And we've had people ask, like, why are people coming in, or why did they come in before? And it's really because they couldn't get in. Dental clinics were closed. And so now it's just kind of people trying to get in and get seen. And there's constant ongoing, and economic stressors with food and gas costs. It was already tough before, but it's even, worse now, for Indian people and everyone, across the world. And the steps forward that I wanted to, so all of these challenges, we should be focusing on relationships and connection and outreach to promote, positive in-person models to really improve that trust, health and happiness and community that's important to tribal communities and really to all people worldwide. And so we should be really looking at that because prior, Indian communities have already, including my own, have proven resilience and really have that strong foundation of, and family and community. It's really those connections and that understanding to systems around us, and really for us to be able to, be sovereign and be able to kind of self-govern in how we feel, the healthcare system or other systems, in the U.S. should happen, and what makes sense for tribal communities. And so I just wanted to share that with you, and just really, we need a global shift to connection to support, healing for all.
Thank you.
And this,
Oh,
and this is a picture of my son. He's not this young anymore, but
we
this is my
don't
son here.
actually. We see you. We don't see the pictures now. Work on the picture. Find the picture.
Do you not see the picture?
No, dear. Yes, when you disconnected before, I think it undid the screen sharing.
Oh, okay. I'm sorry. Let me just show you this because I think you guys will enjoy it.
You can reconnect it because it will be very nice to see them indeed.
Yeah, Chinle. That means I thank you all. And then this is my son.
Let's see.
And then to read more, if you're interested on the history of the Siletz tribe, there's this book that's been published by Charles Wilkinson, who actually just recently passed away.
Wait, Miranda, we don't see the images. So if you can perhaps just tell us, so we
Okay.
We don't see the images. It says Miranda Williams has started screen sharing, but it's dark.
Oh no. Okay.
That's okay. I mean, your presentation is so rich. It's not a terrible thing. It's not terrible. Just try, and if we don't, let's just move on because it's okay. It's okay. You can complete it afterwards, and we will heal the recording.
Yeah, and again, I'm so sorry.
Please don't be, because your presentation is so wonderful. There's no reason to be sorry about anything.
Can you see it now?
Don't see it.
Okay.
Uh,
All right.
Robbie, can you help, please? Robbie?
I'm here. So when you share the screen, there should be a couple view options that you can choose from. So maybe try choosing one of the different screens in the options. That should help.
Okay. So let's see here. Oh, I see what you're saying. Can you see it now? Oh, goodness. I'm sorry.
Yeah, it's all right. Robbie, make sure that you get it and fix the recording, okay?
You got it.
Fantastic. So don't worry about it, Miranda. There's a technical way of doing it. You share it with Robbie and the recording will include it. Okay?
Okay.
Perfect. But what I think the richness of your presentation truly augmented the others. While we are on the land of, it's okay, you can stop that so we can start the dialogue.
Okay.
With everyone. So because I'm sure the people also would like, let's see, I also have to have everyone. While we are on the lands of the Lenape tribes, I'm so happy that we are connecting to the rest of, to all of to the middle and west coast as well. So, and part of what you were emphasizing, which I think is almost a love gift to the whole of the United States today, which is, I deeply believe that the United States is still in shock about COVID, and it still has not even begun to grieve for the devastation in COVID. And today we are giving a love gift to the rest of the country by acknowledging the grief, right? And by you pointing out and focusing on the grief and the ways of grieving, which I would like all of you to speak about, actually. So hold that thought, because I just wanted, so please, this will be the first question I'd like to dialogue on, because I think that puts us in relationship to everyone and the rest of the world when we talk about COVID, right? You have given the world so many ways of thinking and feeling, but I also wanted to make a very brief comment that part of what you're all saying is part of the vision of the center, that is that everything, when we talk about anything in life, it is related to the life. It's related to the multi-dimensional way of being that we all have. And when it's traumatized and in any way, part of what we have to do is, in my theory, actually, I use the term, is identity healing. It's not only healing from this or that or the other. It's always asking, who am I? And how am I in relationships, right? And our connections. And you spoke so eloquently about that. and so generously about that. So thank you. And thank you for the gift, but let's share indeed more thoughts about the issue, grieving, the challenge of grieving. The task of grieving is part of healing. Who wants to, David, we haven't heard your voice for a long time. So would you like to be first? Let's repeat the same order, then we will, for the next question, we will do the other way. But don't feel constrained by this question. Please, this is the time for each one of you to comment on all of the presentations or ask questions of each other. So David, feel free, please, go ahead. And the audience, please, any questions, any comments, please, the chat is open. Thank you, David, go ahead.
So, okay, well, so, you know, I'm not Indigenous, of course, so like my, you know, it's more as an observer working here but just to acknowledge that, you know, the experience of grief amongst patients who I take care of is very, very profound. You know, there is a way in which usual life almost comes to us, you know, seems to almost come to a standstill. You know, while at the same time, I think for Navajo, there are prescriptions that try and, you know, limit the period and encourage people to move on in a way. You know, the other thing I think your question raises that, you know, at some point, it was so clear to me, you know, that grief was important and profound, and, you know, particularly like sort of linking it with the care of chronic diseases, which is what most of my day-to-day work life is. So I went to the place where we do literature searches, and I was kind of shocked that there's almost nothing written about the intersection of the experience of grief, you know, the multiplicity of cultural ways in which people might enter into grief and understand it and transmit it and think about it, and chronic disease care. And it just sort of shocked me that such a kind of fundamental experience of human beings has not been, you know, explored and thought about. So I'll just say that much. Thank you.
This is so important. This statement is extremely important. Thank you, because you have done your quote homework, and it's missing even in the literature. So, which is a silly thing to say, but when I mean by even in the literature is even the smart ones among us who understand the integral relationship between trauma and grief and healing. Where are we? Where is our wisdom? I must say I have written about it, but as a multi-generationalist, we also know, as you pointed out, Miranda, also, that if we don't mourn at one generation, it becomes the task of the next, and the next, and the next. And David, it's interesting because you did mention the concept of death of despair, which reminded me of a very close friend who is no longer with us, who spoke about PTSD as as a disease of despair. So in a sense, you are addressing it, but not quite, you're on the edges of it. So this is amazing webinar in the sense of how many lessons we are sharing with each other. Anto, dear, please, any thoughts that cross your mind, any lessons for us and for everyone who's listening?
Was the question on grief? Yeah, I feel like the scary part that people should be aware of with grief for Indigenous communities, or I would say for my tribe, because I could only speak on my tribe, is that the grief is also the grief of loss of culture. Because we know that the pandemic made so vulnerable groups such as elders were kind of, the I wouldn't say target, but they were definitely the most impacted. And the worry was that elders are like our knowledge keepers. They have so much wisdom and life experience that it's just irreplaceable. You talk about your library, and our elders are our libraries. And so this virus and it being one of the things to take a lot of elders, I think is more of a collective grief, that we had to reconcile with and are still reconciling with, and continue to. So I would say just like for the like, I don't know how to say it in a better way, but we're like in it together in a way, and that also brings some support and comfort, because we know that it's not an isolated situation, it's not an isolated thing. So and then the loss of language too with our elders, they have our language, and I think that also leaves us with some grief too, because time is passing for us, and we're trying to retain as much as we can from them as quickly as we can. And so the pandemic, really challenged us and made us think about what was important. And I think the theme of today is what I'm hearing is connection and relationship building. And I think that was really what was heightened, and where we had to direct our focus on is that connection. And it also like grounded us in, our values even more. I think when you're challenged and you're faced with obstacles, your real character comes out. And I think the really beautiful aspect of Pine Ridge and Oglalas over here is that they really turn to taking care of each other, just as a basic principle of like, you are my relative and I'm going to take care of you. So we are technically financially the poorest reservation, but in my eyes, we're the richest, because we still have that value of a person and that value of connection, and that's what makes us successful. And so that's what I think about grief. I think it has a lot to teach us, and brings us closer together too.
Yeah, and maybe you can also speak a little bit about rituals. We talk about grief, I think rituals, and you're speaking about culture, which is extremely important, and part of the issues are rituals. Can you teach us a little about that?
I can't really share too much about our rituals, because it's like they are safeguarded with our people, but I could say that it was like everywhere else in the world, like we had to limit the amount of people, or like even just having funerals, which was really difficult, because that part and that aspect of prayer and being able to comfort and like be there for the families was kind of severed during that time. So can you imagine having to go through that alone, because of all the restrictions? Like that aspect was difficult. And so like the ceremonial rituals were also impacted in the sense that we had to like put a pause on them and and not get any more or endanger any more else with the COVID at the time. Yeah.
Thank you. And before we go to Miranda, I want to also share one issue that you pointed out to so wisely, Miranda, which you said it takes time. What a wise comment. However, think about the fact that in modern time, if everything is good, even when I need to contact you, if you don't answer me within the first day, I feel something must be wrong. Right? And the American culture at large, that was the first thing I realized when I arrived in this country. It was all instinct. This is a pearl of wisdom. Thank you. And it's connected again to another point you raised before, Miranda, which is the relationship, not just to speak about the relationship in the abstract or just you and me and my family, etc., but to think of the relationship of a patient with a health system or a person with any system, right? Because I have written a great deal, some of you know, and I mentioned it about reparative justice. You have extended it to say, well, and David and I spoke about it in the past. New York is not very good at it either, about reparative medicine. You know, doctors today are supposed to give us only 10 minutes per patient. We are supposed to treat massive trauma in 12 sessions. Would you speak more about it, please? Go ahead, Miranda.
Thank you. Are we still on?
Yes, we heard you. Thank you. We hear you.
Oh. Are we still on grief?
Okay. Yeah, on whatever you want. Yes. This is your time.
Well, kind of speaking to grief, and I know that, you know, definitely it's one of those things, like with, you know, tribal communities and families, it's a time where you're sort of transitioning into, you know, another part of your life or world, and you know, it's an important part, but definitely there's ways to do it. So, you know, in the Navajo, you know, in the Navajo way, they have their way from when there's a loss of a community member, from where it sort of ceremonies sort of stop, prayers sort of stop, and then it goes through that process. And so, and that process involving, you know, gathering of people
so
during that
you're talking
process.
about not only repairing the wound, but repairing the repairs.
Right.
Fantastic. Right. Mm-hmm.
And during, you know, the time of COVID, there just wasn't that ability to do that. And it was the same like with my own community in Celeste. You know, it's a celebration of life, you know, celebrating that person, talking about that person, and coming together to do that. And people just weren't able to do that. And, you know, there's some families who spend, you know, there's like they have to be put into earth within 3 days. And so families will spend that time with family, or with the family that had passed on, so they're not alone. And we couldn't do that. And so, but there's that whole process, even from where I'm from, the tribal community that I'm a part of, where it just, during COVID, you just didn't, you know, we weren't able to go through that process of grieving. And so it was hard, it was difficult. And, you know, even now, you know, there's stories that were shared with me that people are still kind of feeling at a loss because they didn't have that opportunity to go through that process of healing. And so, and for myself, my grandma, who I'm very close to, had passed away from COVID, and it was just really hard. And I start crying, but I'm not the only one that this impacted, whether you're tribal or not, but it made it really difficult. So through that time, you have that year of grief, and then you have, your giveaway, and you're going through that process with your family, and there wasn't any way to do that, and so it was really tough and difficult, and you really draw strength from your family, from your community, to kind of get you through that together. And so Poe was talking about, that collective grief, even though you couldn't go through that process, you did that still with your family and your community, but in a different way, which was really hard. And really, I really liked some of the things that Poe said about it. You're in it together. You're your tribal, whether it's your tribal community or other tribal communities, you're in it together to get through this. And so it's true, that is what happened, but it was so hard. And when I reflect and think about it, and even now, those beginnings again, to be able to kind of grieve and go through healing, that's been really nice and very emotional. It really makes you reflect and think about, the loss and, those times. And even when I was in the Navajo Nation and seeing people go through that was really difficult. So, but it still brings up, those feelings and during that time. But I appreciate this discussion. It needs to happen, and not just in tribal communities, but globally on the impact of it's had on healing and grieving, for the people that mean the most to us.
Actually, some of your colleagues are writing directly to you in the question. To your presentation. So Megan Ross writes, I think Miranda is being modest in that despite restrictions and horrors of COVID, she worked hard at maintaining connections with the people by organizing and overseeing, providing food and necessities to patients and their families to keep them safe, from shopping off reservations and making sure they had what they needed. This is amazing. Okay. This was for hundreds, if not 1,000 families. Another miracle. We have a whole bunch of miracle workers here. This is amazing. So this was delivery of supplies, a good connection with the people, of course. Thank you, Megan.
If I can just say something, so also preceding the pandemic, Miranda had this amazing relationship with all the community health workers. So the Navajo Nation has community health representatives. It's a tribal function. IHS historically doesn't play so well with the tribe. And also, there's kind of these class issues around, doctors versus community members when it comes to, taking authority and responsibility. Miranda was a community health representative in Siletz preceding her work in Navajo. So she knows that, she knows what it means, and was the only person within the Chinle IHS to kind of have uniformly respectful, productive relationships with the community health representatives. So that then when the pandemic happened, we were so fortunate that she had built all those relationships so that many of the functions that, tried to happen in the homes to support patients that were sick but didn't need hospitalization, had to quarantine but had no resources in their homes. Miranda was this like incredible pivotal person, and of course she brought her joyousness and laughter and smiliness and, sense of that, of course you be connected to people. So she brought all of that to that work. And I think that's a little more about what Megan was talking and describing. It is just like phenomenal and amazing.
Yeah, we are so lucky. This webinar is totally precious in each one of you. And for I can see that you want to say something. No? I don't hear you.
No, I'm just listening and learning, but yeah.
So let's go on to the next question and statement from Steve Flynn. Thank you for being here also. To my former colleagues, David and Miranda, how was the impact of the pandemic on the healthcare workers at CSU, CHRs, public health nurses, medicine people? So that's one question he's asking. Thank you, brilliant question. And two other questions. We can have webinars on each one of them. What are the post-pandemic changes? This is for you too, Anpo, please. What are the post-pandemic changes in the Native communities on daily life? Maybe we take one question at a time because these are huge questions. Let me just read them together. But so the second was, what are the post-pandemic changes in the Native communities on daily life relationships, etc.? And his next question, very important, I'm dealing with all my friends with that, is long COVID prevalent in your communities? And let me also just say, quote Megan again, because she is on grief still. She says part of the intensity of the grief is related to the smallness of the communities. COVID had a face, not just numbers, as it was of reservations. Every single family was intimately touched by COVID. And Maggie, so let me throw it all at you, because these are these are core issues in this discussion, and you all can see them in the chat. And Maggie Israeli, to everyone, thank you for sharing and emotionally connecting with us. Miranda, okay, and Miranda, you're writing back instead of answering all of us. So, oh, thank you, Megan. It takes a village to raise a family. Exactly. and Maggie is writing to Anpo. Thank you for your leadership. What do you see needs to come next to address and or prepare for meeting the mental health of your people? It's a very small question. We can have a seminar, an ongoing seminar on that. I can, no, you have to join the working group because it cannot work without all of your wisdom. So of all these questions, core questions, each one is a whole seminar subject, of course. Try to do your best. Go ahead. And remember to unmute. Anpo, please, we haven't heard your voice for a long time. Can you unmute?
Yeah. I was gonna start with the post changes that we see. One of the more beautiful aspects of what I see now is that there's a mentality to make things more accessible on the reservation. And I think that's probably amazing. So we were talking about telehealth. What I know is like sometimes it's really hard for people to even go to the clinic because it's like an hour away, or and so having that option, I think they might have ended it recently, but when it was there, I think it was really helpful because it kind of alleviated that barrier of getting somewhere. Because if you don't have gas money and you don't have a car, it's really hard to get there. So I think just being more cognizant of accessibility is one of the really good changes, and I think that goes for everywhere. And then to the other question about addressing and preparing or meeting the health method. So I'm not really a mental health worker. It's kind of like a whole different thing and a whole different approach. But what I do and am focused on is the empowerment of young people, and empowerment of young people, but just my people in general. And I am here to get rid of as many barriers as there are, because I know what it's like to have them in your way and they don't need to be there. And so I'm really there to, like, for instance, what I do as a volunteer work is I train Oglala Lakota college students, tribal college students, how to collect data and collect water samples, and just like arming them in that fashion. And so that's what I do, is I make things accessible. I don't believe in barriers. I don't think they need to exist. And if we can remove them, we should. So that's kind of how I think about the world. And so with the mental health aspects, I think just leading with that, being the change that you see, and hoping that elevates people in their community or inspires them to do something they want to do in their lives. So that's that. But there are a lot of mental health workers in my community that are doing a lot of good work, and traditional leaders and all of that. So I feel like that's their realm. But thank you for your question.
I'm sure you're too modest, but we cherish it. And thank you for focusing our attention on the amazing inspirational power of youth and the young, because so Miranda, please, and David and Miranda, you have plenty of questions.
Well, I think some of it's focused around the pandemic on healthcare workers in Chinle, with the CHRs, public health nursing, and medicine people. I know before I had left, the CHRs, public health nursing, and public health in general, I feel like that relationship, and even the clinic, has been strengthened. Definitely, there's some work that still needs to be done in order to, to continue that. But I feel like during pandemic, we worked really well together. And I feel like, for me, just really understanding, their system and how they're able to work, and how I can kind of meet, because when I worked in Chinle is an Indian Health Service clinic. Our CHRs, they are with Navajo Nation. And so, there's always sort of that piece on, like, this is what I do, and it's like, how can we come together to make this happen? And so, but just really understanding that part, and how, our relationship and respecting, our roles, and trying to figure out a way how we can, work together, I think has really improved. And I know even when Dr. Flynn was with Chinle Service Unit, he did a lot of work around trying to get them into the electronic health record, so that they can document their visits, in home, because that's really kind of another, view or lens into a patient's life, and really trying to capture that, and working with providers so they sort of understand, that the importance of, this other resource that's on in the community and how they can utilize them, and really showing how, like, if a provider were to go out, and I think, Dr. Goldberg, David has done this too. In order to go out to a patient's home, it could be like a 2-hour journey one way, and then, charge. So it's like that's like half a day. So really showing through the lens of a patient, like, what their journey is like. So they're coming in, doing their medical visit, but they're also doing their grocery shopping. They're also going to, check their mail, and they're doing all of these things, like a one-stop shop while they come into town. So it's just a really big thing for them. It's more than just their medical visit. They're coming in to do other stuff too. And so really, like, understanding that part of, the patient, and really that role when CHRs go out and do a visit, what that may look like. And then also really delineating those roles and responsibilities between a CHR and a public health nurse, and how they can work together as well. And so there's been a lot of work.
Could you just explain to the audience what CHR stands for, please?
Oh, sorry. It stands for a community health representative. They are sort of
the letters.
Yeah, they are. Yeah, and they work out in the community. They're community members who speak the language, understand the culture, and they're kind of that bridge between, patient, provider, or others that work at the healthcare facility on, what's happening in the home for the patient, so they get the resources they need, or care that they need that's supported. And so right. And then the medicine people, which we have our Office of Native Medicine, who are integrated into clinical care. So they have sort of a voice into our healthcare system, and sort of how, we want to, provide services to the Navajo people. And so it's really nice to work with them, because they kind of give you both kind of the language and sort of what it means to people in the community. And then that way you kind of have an opportunity to change things up. They, integrated into clinic, they're able to then be able to work with patients as well as providers on, and this was both, Dr. Flynn and Dr. Goldberg on working with patients on, or we're working with Office of Native Medicine on, and David can speak more and about this since he's there currently, but really just, what does it mean to a patient, like as far as that traditional medicine part of it, and then kind of meeting it halfway with the modern medicine. And I think that was some of the discussions I believe Dr. Flynn also had with our Office of Native Medicine director years past, as well as with Dr. Goldberg. And so I apologize, I keep calling you guys David and Steve. They're actually very close friends of mine, but they've done an amazing job in working and with our traditional medicine, and in order to get that integrated into services, because it really is important to the people of Navajo. Otherwise, if that part is not respected, there could be parts of their treatment that they don't do. So really just understanding that and bringing in, those services into a patient visit, so they understand that this is only part of the way of, healing. There's this other part of the modern medicine that's, part of your treatment as well. So, and I know for myself with Celeste, it's, we have CHRs, and we don't have public health nurses, but we have community health who goes out in the field that provides services. And I feel like everybody's not quite there yet in my community. It's always sort of like, everybody's in this urgent sort of reactive response. And it's like, let's slow it down and, and let's like think about like what we're going to do rather than kind of be more reactive with responses. And it's tough. I think that it's not just, and maybe at some level it might still be in Chinle too, but it's really kind of slowing it down and really thinking about the people and what they need, and you know, what is the best way forward to support people and their care and services that they need. So I'm going to stop there because I talk a lot. But.
Thank you, Steve. And I invite you to become a steady family with us. You've challenged some of the best people here. and I don't want to be remiss by not adding that I think part of Miranda's wisdom is because she's a woman and a mother. And the medical profession, indeed, and any healing profession, and any wise tribes, including those who don't even know that they are, take seriously and respect profoundly the wisdom of women and mothers. In healing and taking care and protecting and raising people to be the next generations. David, after focusing on women's wisdom, go ahead. Steve challenged you too.
So is it okay if I take a pass? I just feel like Ann Poe and Miranda said so much, and I don't feel like I can really add to.
Oh my God, so much modesty and one panic. Oh God.
Yeah.
I really think it's okay, and I think it's exactly a wonderful note to summarize how we all feel. And Anpo, is there any, or Miranda or David, take a step back for a moment. Just think if we missed, of course, we have not covered much of what needs to be covered. But if take a step back, sort of take a deep breath, ask yourselves, is there like a message you want to leave people with? That you would like to add. Of course, we will continue to with these webinars. This is such an amazing center event, and your brilliance and wisdom has added so much. But is there any message that you would like to say that you feel distills maybe a thought, or we will see you again, so don't feel it's the last word. I hate that phrase, last word, but anything that you'd sort of like to leave people with in addition to the richness of what we have shared together with your kindness and modesty. But we go by age. David first, Miranda second, and for last.
Perfect. So just, the words that Ann Poe said earlier on really have stuck with me in terms of when she described at the moment of crisis, both how historically part of what happened with the reservation system was to cut people off from the larger world, and then to actively think about what that means, and how do we not stay cut off from each other. I think she also used language of humility, which has often not been present, particularly when people from kind of bigger established institutions reach out to, communities that are perceived to be poorer, where the culture is not recognized. So, I think that kind of that connection and humility, seem like such important lessons from this presentation. And, like I know Miranda well enough to know that she sort of embodies that, but I think Anpo put words to it like so beautifully.
Thank you. Miranda, you're the next younger. You're the younger one. Go ahead. And then we go to the youngest.
I'm just kidding. Well, there was two things I wanted to say, just to kind of, as far as like gaps in what I just was, sharing, and that was really around public health nursing. I know Megan is listening as well, and I was thinking about her and the work that she did with the Navajo Nation, and just wanted to acknowledge that because she had, this is where like these years of connection come in, where you have our CHRs who, are community members, and as well as our public health nursing, they're also community members too, but they definitely have different, roles and responsibilities in part of that process, as far as care and treatment for patients. And so I just wanted to acknowledge that because I didn't think I did that as well with the public health nursing. And when she was there, and I had a pleasure working with her on mobile health services and in other areas in public health nursing as well. And she had that relationship there, and it was definitely acknowledged and respected by the people of Navajo. And then I just wanted to make a comment about my kids, just, my children and being a mother, and, really, this is kind of how really I live my life and I try to stay in the present. Is just, my kids are like, they're always looking at me and asking me why I do things, and they really make me learn a lot about myself and really make me do reflection. What am I doing? And so that's actually something that I constantly do, and I try to do, and I think it's easier now because I have kids, but I think it's so hard to do that at times, and really, doing that reflection, not really thinking about, what I think about things, and really looking at, perspectives in a different way, and, how others think about things. And that really should be taken into consideration as we're kind of, trying to, move things forward in a positive way, especially, coming out of this period of COVID. And so I just wanted to say, and I, some of the things that I really liked out of these conversations, around humility, around, just, building relationships, and how important that is. And, as far as connection goes, we're all, and this is not just, an American Indian, thing that needs to happen. It's worldwide, it's global. And we should all be working together to strengthen that connection between one another. And so I just, that's what I wanted to say, and just wanted to thank everyone for, allowing me to be here and being a part of this discussion. Thank you.
Thank you. And Anpo, where is our youth? Our leaders of a leader of the future. Not that you have not been already a leader, please, but we depend on you for onward.
I would say like one last thing to do, which is I'm really grateful to even just be here and speak on this webinar, is just keep investing in the voices of youth, especially Indigenous youth. And I say that because a lot of us already prioritize elder voices. Like we already highlight all of the really important things that need to be said by them. We're the ones who put that, we elevate it, we try to bring it to life in action. So we're really under the guidance of that. And so continuing to invest in us, like no matter what, financially, like funding, scholarships, I don't know what kind of investment, even just letting me be on here is an investment. And I'm really grateful for that. And so, yeah, I just keep investing in us and trusting us and, guiding us. I think that's always something I'm always open to, is always being coachable and teachable, because I have like a growth mindset for life. So, I'm always willing to learn and then grow. So, but yeah, we have the energy, and we want to continue the work that you guys do, that's kind of where it comes from, is we don't want the work that you do and spent your life committed to and doing to go with you. We want it to stay here. And so that's kind of where I see my position as a youth. So thank you.
Well, you're in our center one way or the other, so in every way. So that's for sure. Miranda too, if you find time to breathe. And yeah, and in fact, Anpo, we spoke about in the future planning a webinar on the environment, which is part of your integral part of your expertise and you and Indigenous peoples. Finally, the world is acknowledging the international community are the stewards, have been the stewards of the environment, and we all must learn. So we're looking forward to that webinar. And Miranda, you just think about the next one. And David, you are via family a member. Can we see the chair of co-chair of the working group in Indigenous people show her face? Is she here? Hi, Mary.
Hello, I've been listening.
What a resourceful family we have.
Yeah. This was an amazing webinar. Thank you, Ampo and Miranda and David. It really was meaningful. A lot of lessons taking away. Thank you.
Yeah.
And I hug you all and look forward to continuing. Thank you. Yes, thank you so much.